All right, everybody, thanks so much for coming. My name is Nick Beckett. I'm the events coordinator for the Center for Community Health and Engaged Research, also known as SHARE. We put on these ABRC, Arizona Biomedical Research Center workshops every year, usually do 5 workshops or conferences every year. This year we did 6. Back in October and March, actually, we did a 2-part workshop with Dr. Sam Sabo. Let me look at my cheat sheet here. And that one was titled The Science of Community Health Worker Sustainability. Really great conference. We did the first one down in Fort McDowell at Wecopaw Resort. And then the second one we did up here at the High Country Conference Center, but that focused on CHW workers and Medicaid and Medicare billing. Really interesting stuff if you're a CHW worker. And we actually have those recorded. And so there's some great resources on those videos, which I will talk about more at the end of this. And then in November, we did another workshop with Dr. Julie Baldwin, which I don't want to butcher the name. And that was developing nope, that was not that one. Sorry. Innovative approaches to enhancing the behavioral health workforce in Arizona. And actually, we did that one in this room. And so it brings back some memories. But that was also a great workshop. Again, great resources. So again, these will be recorded and available on our YouTube channel. And these go back 8 years. And so we have a ton of videos on our YouTube page. If you're bored and just want to be educated, I would definitely check them out. Again, in March, we did the second workshop with Dr. Sam Sabo. And last week, we were actually down in Phoenix at the Banner University Medical Center doing a workshop titled AI for Good, Advancing Care and Improving Lives. Very interesting topic. Basically, how a group of radiologists are integrating AI into scans, into scribing technology, and some interesting results that was kind of unexpected. And so I would definitely say check that one out. And then today is actually a 2-parter. We have the workshop tonight. Tomorrow we have the conference portion of it. And so we have, I believe, like 7 or 8 of our scholars will be presenting their research for the past year. Our community partners will be there. And we also have a speaker, Lee Yaiva, which you'll see his bio up here during dinner time. I'll have all the bios of all of our speakers playing. And then next week, we wrap up these workshops. We actually head down to Yuma, where we have our 8th annual border conference. And we work with Amanda Aguirre, who is a former state senator. And that one's very successful. We keep building on each of the previous years. About 150 people show up, and 60 to 70% of those are from Mexican universities. And so it's really exciting seeing the research that's happening in northern Mexico, compared to the research that we're doing in public health. But that's all I have. Thank you again so much for coming. And I'm going to pass this on to Ramona.
Thank you, Nick. I get to make the opening remarks, and I want to welcome all of you to the 5th annual Community-Centered Addictions Research Training Conference. We call it very lovingly CCART. And it's hosted by the center. This conference is hosted by the Center for Community Health and Engaged Research, which is SHARE. We're delighted to have you here for what continues to be a meaningful gathering of researchers, community members, practitioners, and advocates committed to addressing addictions through a community-centered lens. So we hope that we exchange ideas, we strengthen partnerships, and talk about research that's grounded in real needs and the strengths of the communities we serve. So I hope you will have a chance to engage in discussions through this workshop and as well as tomorrow, and connect with those who are really committed to making a real difference. I would like to also extend a sincere thank you to those who helped organize this workshop. We have Nick, Amy, Shannon, our photographer, and all others that made this possible. So thank you. It is now my distinct pleasure to welcome our keynote speaker, Dr. Elizabeth Anthony. And Dr. Anthony is an associate professor at Arizona State University, whose work focuses on adolescent health and well-being. Her research brings a refreshing and powerful perspective by highlighting joy and relationships as essential protective factors in the lives of young people. Through her community engaged and SAMHSA supported initiatives, she has advanced practical evidence-based strategies to support youth across schools, families, and communities. She's also the author of Centering Joy, What Adolescents Teach Us About Thriving, a work that challenges us to rethink how we approach well-being and resilience. Dr. Anthony is deeply committed to bridging research and practice in ways that are both meaningful and impactful. We are honored to have her with us today to help us better understand not only the challenges in addiction research, but also the strength, the resilience, and the potential and joy within the communities we serve. Please join me in warmly welcoming Dr. Elizabeth Anthony.
Well, thank you for such a wonderful introduction. I was listening to it and thinking, wow, that's a lot of different things. So I am just really grateful to be here with all of you today to share with a little bit about the work that we're doing down in Phoenix in Maricopa County, and hopefully to also learn from you about the work that you're doing. So I'm excited to do that. The title of my presentation is The Power of Protection. So as Ramona said, my research area is really how adolescents thrive. So I'm most interested in protective factors in their lives. So most of the research, as many of you know, focuses on individual risk factors. So why did a young person start using substances, for example? And unintentionally, I think, ends up blaming the young person for their own use. And so I have been interested in what are we doing systemically to try to help protect young people from substance use that's problematic. So I have been really excited to be a part of this grant because it allows us to focus on family level, school level, and system level protective factors. So when we think of protection, or I think of protection, I think of what helps bolster a young person in the face of stress or distinct risks. And so we know that there are many different types of protective factors that exist at all the different system levels. But really, it belongs to the system to try to produce more or to provide more protection. So young people who are exposed to substances or heavily using are frequently so overwhelmed that it's difficult to tap into some of those protective factors. So I'd like to introduce you to our team. I'm the principal investigator of the state opioid response that is funded through SAMHSA. My co-PI is Dr. Justin Hardy. He's a professor at ASU also, and he studies young people in the foster care system who are aging out. I have a wonderful research assistant named Nika Hernandez, and she's a doctoral student who's currently working on her dissertation as we speak. So I like to always start with a story. So I want to tell you about a young person that probably will sound familiar to you. This young person's name is Taylor, and Taylor was sexually abused as a child. And when she hit her developmental milestones and started going through puberty, she decided this was too much. Her emotions were up and down, up and down, up and down. She experienced a lot of mental health concerns. So as we would guess might happen, Taylor fell in with some kids who were using. That felt really good to her. School became less important. Friends became more important. School became not at all important. Taylor dropped out of school. And most of her friends also dropped out of school. Taylor started living on the street to fund her substance use. So this is not a story that's probably a surprise to anyone here, but I tell you this story because I knew Taylor's parents. And so I watched Taylor's parents, and Taylor's doing great now. I'm happy to report, but I watched Taylor's parents try to figure out how to help this child. So they had two other kids who were doing great. Taylor just seemed to be an anomaly, likely because of the sexual abuse, as we would imagine. But this is a family that was trying to bolster family level protective relational factors for her. And they were bombarded with a system that sort of rejected what they had to offer. So I saw these parents struggling with caseworkers, struggling to get her into a weekend program, trying to get her to stay in residential treatment. She would run away. And so the distress of the parents caused me to think, what are we doing systemically to help young people really? I mean, we say, well, that's a troubled child. Do we just count her as a loss in the system? Or do we say, this is a young person, we can help? And so what I love about the state opioid response is while it focuses on treatment, it still covers the continuum of prevention, harm reduction, treatment, and recovery support. And so we're able to start working on what were some of the school factors that maybe could help someone like Taylor. What are the systems working together that might help someone like her? So it is a 3-year project, and the purpose is to address gaps in care for adolescents aged 12 to 19 with substance use disorder, specifically opioid use. So as you probably know, treatment uptake is very low among this group. So if they have services at all, very few of them are receiving specific treatment for opioid use. In Maricopa County, there are very few doctors who are willing to prescribe medications for opioid use disorder, despite the fact of evidence-based treatment. So we're looking to sort of address these gaps by bolstering the capabilities of some of these professionals to work with these young people. So in Taylor's example, a teacher could have identified her opioid use and generated an intervention much quicker than someone else because the teacher sees her every day before she dropped out. So we might think of it that way. So in our first year, we did a needs assessment to survey Arizona community members, so parents, caregivers, school professionals, child welfare, caseworkers, juvenile courts, to assess what is the perception of existing services and where is the unmet need. So how severe is it? And then what are some of the treatment approaches for adolescents? We also established a treatment advisory board. So this is one of the parts that I think is most impactful. But we have on our treatment advisory board psychiatrists who work with adolescents, nurses in the schools, social workers in the schools, and teachers. So we have a variety of people who contribute to helping us understand how to intervene. So hopefully you can see this in the back, but it shows sort of what the substances, so the question is, which substances do you think would be the highest priority for treatment programs working with adolescents in Arizona? Illicit opioids being the number one, and alcohol being a close second, vaping pretty close, and cannabis pretty close as well. The types of training, so not surprising, especially given the case example I gave earlier of Taylor, but youth involved in the criminal justice system is a high need area, as well as trauma-focused treatment. So we talk a lot about trauma-focused treatment, but it's pretty hard to find trauma-focused providers that actually follow through with all of that, all the way through services. In year one, we've also done a number of webinars, and these are free and available to the public, and they're available on our website. So the adolescent treatment for substance use virtual town hall was one I hosted with some colleagues, and we were able to find out what does the local community think about where the gaps are and what we should be doing. Another one was bridging between child welfare, juvenile justice, systems in order to provide treatment. So we know that gaps in the service systems is what causes some of this difficulty finding treatment. We also have had some treatment-focused specific trainings, such as how to use naloxone and for schools to help identify Narcan in the schools. So I was surprised to find out Narcan is not in every single school in Arizona. And I was very surprised to find that out. So I think it's both an information source and it's also a funding issue. In year one, we also provided some guides, and there are examples on the table for you to look at and take. And these guides are to be distributed to local agencies. So one of the addressing the gap issues is that local agencies don't always know how to provide services. Surprisingly, there's some resistance again to even serving young people who have substance use disorders, particularly opioid use. And so these are briefs on how to use naloxone, how to identify an overdose, what is medicated assisted treatment, what does it look like, and how can we start addressing some of the barriers that affect young people's ability to get treatment. Just to give you an example of how we're working across disciplines, this is a list of the providers who work on our advisory board. So we have people from probation, a medical student who's interested in this topic, several doctors, a psychiatrist specifically, but several general doctors, and several people from the children's services. And then a school social worker as well. And so these advisory members are able to review our guides so that they're accurate, because when you're putting out information these days, it has to be exactly right. And you have to be very careful what you say, how you say it. And so we have advisors to make sure we're reporting correctly. All of this information is on our website. But I wanted to talk for a minute about our focus for year two, because we're moving into that. And this is the part I think as a researcher I'm excited about. We are launching what we call secret shopper study. Yeah. Do you need some? Oh, up in the corner? Yeah. I was wondering, can you get rid of it? Thank you. So I don't know if you've heard of secret shopper studies in other fields, but what we're going to do is, yes. So they're kind of exciting, difficult to get through your local IRB board, but exciting nonetheless. We will be calling providers and asking what are the services they provide. Specific for adolescents, how many people do they have working on their team? What is the menu of things they provide? And what do we need to do to access treatment? So I have students who will be calling on behalf of family members to do the call, so they won't be identifying themselves as part of the university. And so I think that what we are aiming to find out is what is actually provided. So families tell me and us again and again, it says on their website that they provide medication-assisted treatment or substance use treatment specific for teens. And then when we call, it's not the case. And so we're trying to find out exactly what services are being provided, not to get any agencies into trouble, but to identify the landscape. What do we actually have? And that's kind of one of the few ways of doing it, because again, what's listed on websites is not always what people provide. We are also continuing to do adolescent-focused webinars. So we're excited to talk about protective factors and conversations family members might have with young people in our next webinar coming up at the end of April. The other thing that we do that is interdisciplinary that is really great is the Substance Use Management and Medication for Inclusive Treatment ECHO, which is a long name called Summit ECHO. And this is a professional development training that occurs every other week on Fridays, and it's free to the public and it's free to our community. And we have guest speakers, often people from our treatment board, honestly, talking about current issues and presenting a case. So they'll present a case at the end of their presentation and everyone chimes in and tries to give feedback on that specific case. So there's some information on how to join that, but I find it to be a really dedicated group of people really trying to grapple with some of the tricky parts of substance use. So one of the topics recently was needle exchange and some of the ordinances in the Phoenix area for prohibiting use at parks. So I don't know if you have anything similar going up here in Flagstaff, but there's a lot of controversy around what can happen in parks currently in Phoenix. And so the committee is talking about what can be done about this issue. So before I wrap up, I want to go back to the case of Taylor. So what did work for Taylor was sort of a patch together of a lot of things like this. So the parents were able to locate a caseworker who was able to help link her. She was able to work with a peer mentor, which was huge for her. So no one else would she listen to, but this peer mentor she would listen to get her to a place where she could actually she's still using, but she could actually function in society with a job, with a place to live, etc. And so I think about that in terms of the influence we have if we really think about how to mobilize schools, families, and communities. So there, at least where I work, the schools, families, and communities absolutely want to see their young people thrive, but it's hard. If a young person is entrenched in substance use and not talking to anyone, that's difficult. And so I think from my perspective as a researcher, I would really like to see communities working together collaboratively to address some of these barriers. And some of the innovations include talking across disciplines. So that was a quick overview of our project, but I would love to entertain any questions people have about the project, about protective factors, about any of the work that we're doing. Yes, please. Oh, yes, sir. I know.
Oh, do we need a mic? Okay, I'm usually loud enough.
Oh, yeah, good.
Okay. All right, thank you. So do you know if the SOR, SAMHSA's SOR is still ongoing?
Yeah, that's a great question. So we had a little bit of a scare earlier this year, but we still have our state funding. The SOAR grants are still active. We just have some restrictions to certain aspects of the grant, but overall, yes.
Wow, that's wonderful. I think
It's amazing.
I think you lucked out.
It's amazing. Yes.
Yeah, and then the workshop that you showed the picture of, I have a couple of people down in the Phoenix area that I think would benefit from attending, but they have no formal education in the area.
Yeah, that's okay. And so if you go to the ASU website for SIRC, Southwest Interdisciplinary Research Center, you will be able to find this project and you'll find the webinars and all of the materials I described.
So
here.
It's a webinar. It's not an online, like no one meets at the same time, but this is something that they could peruse on their own time asynchronously.
Yes. Well,
Yes.
we do meet at a distinct time with the presenters and we have an audience, but if it's recorded, with permission, some of our presenters are uncomfortable being recorded in the current climate.
Sure.
But if we're presenting and we record it, then we put it on the website.
But people could come in person and participate.
Yes, it's free.
It doesn't matter who you are. Okay,
Yes.
which leads me to the third question. I have a bunch of people who would be so well for that lived experience board position that you have. How do I get these names to you?
Yeah, I can give you my card. So
I
we're
would love
still
that.
actively looking. As you can imagine, that's one of our challenges, is finding someone with lived experience who's still a teenager, or close,
you want
or
it a
just
teen.
or 18, 19 to speak about their experience. But I can connect with you after.
All right.
That would
Thank
be
you.
fantastic.
Thank you. Thank you.
Any other questions? Yes, please.
Thank you.
So does your program also look at the physical needs? I mean, you're looking at the needs around the substance abuse. Often it's triggered by mental health disorders and other trauma disorders. But if there are physical issues going on with this interprofessional team, do you have providers that are helping with physical health? And with the teenage population, my background's perinatal substance abuse. So I always think about our wonderful teens and being sexually active and also using. So how are you covering those issues?
Yes, that's a great question. So our grant is focused on substance use treatment, but our advisory board, so we have an adolescent advisory board and we have a medical advisory board. So on the medical advisory board, we have practitioners who are addressing those specific concerns. So most of our cases, in fact, are young people who have mental health concerns or have some other condition that they're dealing with at the same time. Yes, great question. Yes, please.
Hold it. Okay. Great presentation. Really interesting work. Part of this is going to come from maybe my ignorance around the use of the word, I think, protection in this context. I hear the story of Taylor. Was that her name, Taylor? And I find myself really engaging with the fact that, again, there are these two other, adolescents in the home who aren't engaging with substance use at all in the same way that Taylor is. And so my mind, of course, then goes to, okay, what are the protective factors of those two individuals within the home that are keeping them from kind of following down Taylor's path? And I know you mentioned the sexual assault, which of course, naturally, folks in the room are very familiar kind of with the correlations there. But I'm wondering, kind of in this idea of like protective factors, is there room to maybe explore maybe the subgroup of adolescents who maybe don't engage with substances and kind of what those protective factors look like? Because I think that largely when I think of protective factors in my line of work, I think of the folks who are again kind of protected from engaging in the first place. And I'm wondering kind of what your thoughts are around that.
Yes, and that's a great question. And I always make the assumption people know what protective factors are, but in the literature, we talk about risk and protection. So risk factors making it more likely, that's a factor that makes it more likely for substance use in this specific example, and protective factors as bolstering someone from the risk that they might face. And so, yeah, you're kind of talking about the resilience literature or the flourishing literature. So why is there another child who also experiences a sexual assault who doesn't end up using, and what are the influences in their life? And so a lot of what is in the protective factor literature does identify those kinds of relationships. So in Taylor's example, her siblings were a huge protective factor because they weren't using and they were going to school, right? So positive influence was within her family. And so we're still figuring it out, but there's no one reason. So that's the one thing I can say about that literature is it's a complex array of things that affect a young person at any given point in time. And so what might make a young person resilient to use at 12 might be different than when they're 16. So that's part of the issue we're dealing with in the teen years is they're still developing. So part of Taylor's issue was puberty hit right when she was puberty sort of generated thoughts and feelings about the assault, which contributed to an increase in her use. And so they're all related. But what we do know is the more protective factors you have at the family level, at the school level, across these system levels, the more likely you are to navigate well. And so if we can bolster relationships with school professionals, with mentors, I mean, it's back to the things we knew way back in the day, but those things work, right? So mentorship works. Having someone who asks, hey, Taylor, how are you today? You know, how are you? You don't look great. What's going on? If you don't want to talk about it, that's okay. You know, safe places to be. And so those are the things we can change. I hesitate to look at the literature that says, well, it's these rigid mindsets that kids have, or it's a IQ issue, because what are we going to do about that from an intervention standpoint? And we can do some things, but I think there are areas of more effective intervention that would be things around relationships. I don't know if I answered your question completely.
No, I think you did. I think it's also kind of forcing me to be more maybe pointed with the actual question that I'm asking. So I'm wondering if there are examples of interventions that prove to be effective that happen before maybe the time of like substance use treatment, like treatment for a substance use disorder, I guess is the question. Because I know a lot of conversation around treatment, and maybe this is revealing kind of where my presentation will eventually go. But I'm just wondering if there are points of contact and points of bolstering, again, these points of protection that happen before even engagement with substance use treatment. And Absolutely. I see this at MOUD for sure, or that you know, this can happen like with naloxone, for example. But I guess I'm curious about other interventions that happen maybe before that point.
Absolutely. And I'm a prevention person at heart, but our grant is funding treatment, and that's what the current administration wants to fund specifically. But if I'm not wrong, Sabrina will be talking about an intervention just like this in her talk. So you'll get to hear it. Yes, but there definitely are. Yes.
I imagine since you deal with the youth, thank you. Is there any, trying to figure out how to ask this, but safe spaces? I know with the youth, you don't want them using period, but in the situation where someone feels they must use, is there anything that provides information or resources, maybe safe needles, or I don't even safe, it just seems like an oxymoron at this point, safe using, but do you cover anything like that?
Yes and no. So part of that is restricted currently. But what I was talking about with the parks, so the parks used to be a place where something like that would happen. But there's a lot of controversy around that because a lot of people don't understand what that means. So people don't understand what we all do, think that we're helping a young person use by providing a clean needle, or we're helping a young person use by helping them find a safe place to use. Never use alone is kind of a harm reduction idea. But a lot of people in the community are resistant to that idea. And I can understand it, but we need places for young people to be. Yeah. For many reasons, not just for substance use. Yes. Yes.
Oh, you're going to hold it? Thank you. Thank you so much, Dr. Elizabeth. That's such valuable information to share with us all. So many dimensions with kiddos and adolescents in terms of substance use. I'm with Southwest Behavioral and Health Services, and we do have OTP programs, one in here in Flag as well. However, this goes back now a few years ago. There is such a tremendous need, and I'm down in the metro area as well. And just trying to shift the mindset with our own BHMPs to provide MAT services. And there are more stringent rules for providing those services but I was wondering if you could give me any new insights to take back home from the psychiatrist perhaps that you're working with.
In terms of how to address the bias or stigma?
The fear of treating.
Yeah, it's deep, right? So
Yeah.
it runs deep. I have asked our advisory board many times, but what can we do to address this bias? And so I think it's complex. So I think it's one of the other suggestions that our team had was to provide sort of a peer support group for doctors who provide medication treatment, where they can come together and talk about what some of the issues or worries they have are. What the one provider that we have in Maricopa County who's on our board talks about her caseload is insane, but she's there to help anybody she can. She's fabulous. And so she's trying to address it sort of one colleague at a time. But I think the bias is societal. And so I think we have to work pretty hard to shift the belief system of people in society. So I use it as a controversial dinner party, cocktail party conversation, but to say, why are we afraid of this?
Thank you.
It's a hard issue. Anyone else? Yes, Julie, yes, please.
Hold it. Oh, you have, okay. Well, thank you again so much for your presentation. You alluded to, so it sounds like in this second year, you're going to be looking at perceptions of services available and that sort of thing too, right?
Well, and availability of services.
Yeah.
So not just perception, but what are agencies actually providing?
Okay.
Yes.
As you can imagine, I mean, even in urban areas, there's a shortage of providers. We really have that problem in rural areas. And so I'm just wondering if you could, and this may be a bit out of your wheelhouse, but how do we get these services, to these youth, especially in these kind of more remote rural areas?
Yes. So our graduate research assistant, who I was just showing a picture of, and some of the other doctoral students drive to the rural areas and talk about our brochures, talk to them about treatment, talk to them about some of the resources that we have. But I think it's a coordinated effort. I mean, I think this is some of what we're trying to do right now, is to make connections that will at least start the flow of communication between groups. Yeah.
I mean, one of the things that we're thinking about is just the behavioral health workforce in general, and how we need to really work more like at the community level with community health workers. And there's even a program, and I'm going to put a plug in for this, that's called the Community Health Aid Program, where we train community workers to do primary care, very basic primary care, and behavioral health and dental health too. So different areas. Alaska has been really successful at using this approach, where we have behavioral health aides in the community, but then they're connected through telemedicine and other means to psychologists and psychiatrists back in the urban areas too. So I just think as a whole, we need to start thinking about that for our state and for rural areas, because there's such a tremendous shortage and such a great need.
Such a great need. And our school social worker, who's on the adolescent advisory board, talks a lot about this, about how to reach the social workers who work in the rural schools so that they're informed of what treatments are available, and so that they have Narcan on campus, so that they're getting the same kind of training. So I think it goes back to what we're talking about in terms of layers of protection, but hit it at the family level, the school level, and the community level if we want to see change. But yeah, it's more difficult for sure.
Is a behavioral health aid the same thing as a social worker, Jules? What is a behavioral health aid?
You will have to come to our workshop.
Really? And when is it? Really? I might be busy. Yeah.
It's similar to a community health worker, but actually there's a certification process.
NAC.
Yeah. Well, not anything. Yeah, we're working on that. We're working on it.
Who are we? Who are we?
I'm so very
Okay. Okay. All right.
Anything else? You're such a good group. I love when groups have questions. I love it. It's so hard to present when no one wants to talk about it. Yes.
So I was intrigued as I was reading up on you and your bio and, the word joy. And I was wondering
Yes.
if you could speak about how you've measured it, how it manifests itself and as a protective factor. And, how do you see it happening and what do people do to increase that,
Yes, thank you for asking about my joy projects. So my joy project started with research studies, 6-7 years ago. So I've always done research with young people in child welfare, juvenile justice, sort of in systems. And one day I just thought, you know what, I'm going to start with a different question. I hate all these questions we ask every time. I'm just going to sit down and ask, like, what did you do that was fun today? What makes you happy? What do you do? And I thought maybe kids wouldn't understand it, but they love these questions. What brings you joy in your life right now? And so I'm talking to a young person in juvenile detention and asking them that question. And they just told me so many examples of things that you would think, well, what would you guess they would say, I guess? I mean, what do you think a young person in that setting would say? TikTok? Video games? Friends, yeah. Music, a favorite meal, sports, yeah. Taking care of their little sister. I mean, tough kid, right? This tough kid saying, it brings me so much joy to take care of my little sister. And I thought, okay, well, I'm going to write a book about that. But so these are the things, that's how it mobilizes, I think, is we use it as leverage. So when Taylor was in the depth of her use, it was hard for her to think of joy, but she still had it. So for her, her joy was tattoos. So she did some of her own tattoos. And so that was her way of expressing joy or feeling joy. Yeah. Yes. Did that answer your question? Yeah. Okay. It's more than that, but that's a start.
Hi, I hope this comes off in a good way, but I was just curious about especially kids, as you said, 12 through 19 and having all these spaces such as schools, families. How do we sort of find out that they need help on a community level? Because so many times when kids act out, it's like, oh, they're just going through developmental phases, they get overlooked. And then it's too late until the risk factors goes into something like juvenile delinquency, and then they're going through withdrawal. What are the steps can we sort of identify to get these kids help?
Great question. It's kind of similar to your question about what protects kids from even using in the first place. But I'm a big proponent of counselors and school social workers. So when there were movements against taking those out of schools, I've been on boards to try to keep those resources because teachers are tapped out. That's a hard job. And so teachers can only identify what do they do if they do identify a young person who's using? What are they supposed to do when they have 25 or 30 other kids? But social workers know how to do that. Counselors know how to do that. And so increasing those resources within the schools, in Phoenix, we had some funding issues where funding was going to school resource officers over counselors and social workers. And for me, that was heartbreaking because a resource officer could potentially be someone who could intervene, but they're probably not trained as effectively. And so I think we need to increase those resources and increase awareness. So the teen mental health there's a lot of awareness that it's a problem, but there's not a lot of solutions for how to handle it. And I think it's more points of contact by positive adults in every environment those kids are in. Yes.
I've been helping with analysis for a long-term opioid therapy tapering project, whatever it is. And I read a transcript and I just keep thinking about this, where this woman had been on opioid methadone for 30 years. And there are people who are trying to come off of methadone, and it sounds like they were just put on it and never taken off. And so I'm kind of curious, what's the long-term research for adolescents, and how do you decide which of them really, how do they not get lost on methadone for the next 30 years?
Yeah, and that's not a question I think I can really answer. I mean, I think that's a great question for our advisory board. But yeah, I mean, I think there are unanswered questions still. I mean, is anyone in the room more equipped to answer that question or want to take a stab at it? I mean, it's complex. No, well, thank you so much. You've been a wonderful audience, and I'm happy to talk with anyone after.
And we are going to break for dinner. Our next speaker will go on about 5:45. And so we got plenty of time to eat. The buffet is just right outside here. We'll go ahead and open these doors. And the restroom, if you haven't seen it, there's doors actually just right outside these double doors that go in between here and 1899. Yeah, help yourself and enjoy dinner. All right, everybody, we're going to go ahead and get going. And I believe Dr. Julie Baldwin is going to introduce our next speakers, our panel, actually. You can just go forward.
Okay. Thanks, everybody. Hope you had a great dinner and a little time to visit with each other. And again, my name's Julie Baldwin. I think I know almost everyone here, but we're so happy to have this event, again, sponsored by the Arizona Biomedical Research Center and CCART. One of the things, and we were just talking over dinner about this, is we're waiting to hear if our grant's going to get renewed. It gets reviewed on Monday. So everybody send positive thoughts, because we want to be able to continue this program so much. So anyway, it's really a joy to be able to introduce our next speakers. And I'm going to go ahead and do a brief introduction, even though you have their bios, but again, just so you know all the great things they're doing. So first of all, Dr. Sabrina Osterly, am I pronouncing that right? I hope so, is a professor in the School of Social Work and the director of the Southwest Interdisciplinary Research Center at ASU, and that was mentioned earlier by Dr. Anthony. She's a prevention scientist with a focus on health disparities, life course research, and the prevention of substance abuse and other behavioral health problems, also among adolescents and young adults, and studies the efficacy, effectiveness, implementation, and dissemination of evidence-based interventions in communities. She also has expertise in longitudinal and experimental study designs and advanced quantitative analysis methods. And we're really excited because, again, if our new grant is renewed, Sabrina and her team will actually be working with us on this next round. So we're super excited. Yay. I'm going to go ahead and introduce the other two speakers too, because of time. We want to just be able to flow right into the next presentation. One of the things you'll note is that we'll have about 20 minutes for each presentation and then about 10 for questions and answers for each person. So our next speaker is Dr. Ariel Roddy, and she's an assistant professor in the Department of Criminology and Criminal Justice here at NAU. She's an enrolled member of the Sault Ste. Marie Ojibwe tribe, and her research focuses on Indigenous perspectives and justice, culturally grounded behavioral health interventions, and community engaged approaches to justice. And her work has received many awards, as you see here, and we're just so thrilled that she is part of our team here at NAU. So let's give her a hand too. And then third, we've got Dr. Oakley Rogers, who's also here. We're so happy to have her here. She was previously here at NAU as one of our associate deans in the College of Health and Human Services. She's a distinguished academic leader and occupational therapy professional with over 15 years of experience in higher education administration. And she's now an associate dean for the College of Health Sciences at Boise State University. She's been involved in developing numerous courses in education, leadership, mental health, and scholarship, published a great deal in peer-reviewed journals, especially in this field, and obtained grant funding in this area as well. And her research focuses on designing and implementing OT programs for individuals with substance use disorders and best practices for clinical education. So again, let's give them all three a hand, and I'll turn it over to Sabrina to come up.
There it is.
Well, I'm so delighted to be here. Thank you for having me. And it was such a wonderful presentation earlier by Dr. Anthony. She set me up so well, and you all set me up so well for my presentation because you asked such great questions that relate to prevention, which is really what I am all about. As Dr. Baldwin was saying, I really consider myself a prevention scientist foremost. My training is actually in sociology, but I've been always in a school of social work my entire career. So I work very interdisciplinary. And as you can see on the slide, I'm at ASU and now direct the Southwest Interdisciplinary Research Center. So I have always worked my entire career really all across the health sciences and social sciences. And so I'm here to tell you a little bit about the work I've been doing with a community level approach to preventing adolescent substance use called Communities That Care. Does anyone here know Communities That Care or thinks they know what it might be? Awesome, because often I have audiences that know a little bit about it, but I'm excited to introduce you to Communities That Care. So I want to start with this question that actually you all were asking earlier, right? How do we prevent adolescent substance use? Do we know how to do that? What do you know? How do we prevent adolescent substance use? And this is different from what we were talking about earlier, right? Before it even starts, what do we do? Do we know how to do this? Keep them busy. Sounds good. What else? Positive role models. Excellent. Healthy coping skills. I love it. All of those things are really important. And we've already talked a little bit about that, right? Protective factors. But really the answer is we can prevent adolescent substance use by changing risk and protective factors. We know how to do that. So to answer some of the questions earlier, yes, we do know how to do this, and I will tell you how. And we've talked a little bit already about risk and protective factors. So I think most of you probably know what they are, but just sort of to get us on the same page, we know that risk and protective factors are malleable factors known to predict substance use or other problem behaviors. We have shown this over the last 2-3 decades that this is how it works. And we have actually identified many risk and protective factors through rigorous studies and longitudinal studies. So the knowledge base is actually there. And as Dr. Anthony was explaining earlier too, we know protective factors actually decrease the chance that a problem behavior will occur, and risk factors do the opposite. They increase the chance, so the likelihood that substance use or another problem behavior might occur. And as we talked about, whoops, I'm going backwards. As we talked about earlier too, we also know that these risk and protective factors don't only occur at the individual level, they really occur across multiple levels and multiple domains. You know, we talked about many of them. You gave several examples. They're at the individual level, they're at the interpersonal level, with peers, with the family, they're at institutional levels. At the schools are really important, but also the community that our young people live in, but also more broadly at the societal level, policies, laws make a difference, but also culture sort of much more broadly. At all these levels, back and forth, you know, as we were saying, it's not only one factor, it's really across these multiple levels and multiple domains that we need to intervene, and it's rather complex. But the good news is that we actually know a lot of the risk and protective factors that can prevent adolescent substance use. Here's just one example of a table that we have put together based on the existing evidence from high quality studies that actually can show in a longitudinal design that these factors actually predict behavior. In the highlighted column is substance abuse. And you can see this table actually shows only risk factors, but some examples of what we've been talking about, right? So for example, at the community level, there's things like the availability of drugs that matters for adolescent substance use, but it's also more general community level factors like low neighborhood attachment, like community disorganization. In the family, it might be family conflict, for example, but also the parents' attitudes towards substance use matter. At the school level, as this came up earlier, right, is academic failure, not being committed to school. And at the individual and peer level, there are things like friends who also use substances. That's a big influence, as well as youth's own attitudes towards substances. So you can see this cuts across many of these different domains. But what you also see here is these little dots mean that all of these risk factors don't only predict substance abuse, they also predict many other behavioral health problems that are really interrelated. So like what's in this table is delinquency, teen pregnancy, school dropout, violence, and also internalizing problems like depression and anxiety. So the point here that I'm trying to make is that there is not one single factor that predicts one specific behavior, but there's really multiple factors, and they predict many of the interrelated problem behaviors that we see. And the good news is that if we intervene on one of these risk factors, we might not only prevent adolescent substance use, but we might actually also impact many of these other interrelated behaviors. And we know all of this. So that's really the good news that I can share with you. And so the answer to my original question is, how do we prevent adolescent substance use, is by targeting risk and protective factors with interventions to prevent these problems. And so, of course, these interventions try to increase protective factors and decrease risk factors. And as Dr. Anthony mentioned, the more protective factors we have, the better. And all of these reduce the likelihood of these problem behaviors from occurring. And again, the good news is that we actually now have developed, tested, and identified many interventions, practices, policies that work. We have, for example, a registry like the Blueprints for Healthy Youth Development. These are registries that sort of curate evidence-based programs and policies. They're free. You can look them up and you can see what kind of risk and protective factors you might want to target. And they tell you exactly what kind of program for your setting, for what kind of population has been shown to be effective. So we actually have the tools to prevent adolescent substance use and many sort of related behaviors. So what's the problem, right? Because we're all in this room because we know it's still an issue in many communities and something we need to take seriously. So what's the problem? It's actually a difficult problem. The issue that we're facing now, we've made such progress in prevention science by identifying risk and protective factors and developing programs that work. But the fact is that prevention approaches that do not work or have not been evaluated yet, so we don't know whether they work or don't work, are more widely used out in practice in the community than those that have been shown to be effective, that are, for example, listed on this registry. This is the problem that we're currently facing. It's not that we don't know how to prevent adolescent substance use and other behaviors. So this is really the topic that my work has been trying to address with what I will be talking about with community-centered care. I don't have time to really get into all the reasons why these either non-tested or not effective programs are more widely used, but here are just some that you can see, and it's something we talked about earlier in our earlier conversation. There are many related reasons why this might not be happening. It might be a public awareness and support for evidence-based programming that also affects, of course, system leaders who make decisions around funding, who make decisions around what are statutory requirements when there's RFPs out for funding. Is it required that the programs that communities implement have to be evidence-based? Maybe, maybe not. And as well, I think there's always also the issue that there's a lack of prevention knowledge and the capacity in our workforce out there. So there's a lot of opportunity also for training in terms of how do you make decisions around prevention? How do you actually implement something well? It's not easy to do, right? And this is where community-centered care comes in. Community-centered care was exactly designed to address these issues. What community-centered care is not an intervention or a program sort of by itself, but it's really a system, a process to build community capacity for prevention planning and prevention work, and so that the community is empowered to select the right kind of evidence-based programs and implement them with fidelity in their communities. And so really the goal of CTC is to increase this community-wide adoption of evidence-based programs to address youth behavioral health problems, including substance use at the community level. And so the goal really is, by doing that, is to achieve broad public health impact, because we know if we did this, we know these programs are effective. So if there was broad implementation, we really could have a broad impact. I think the exciting thing about community-centered care is that a key factor is that it's community-driven and community-owned. It's driven by a coalition of community stakeholders, and it uses data to make decisions and uses the principles of prevention science, so this risk and protective factor framework, to make decisions. And coalitions learn about all of that to make their decisions. And I think the other piece, because it is based on data from the community specifically, it takes into account what the community's specific needs are, what the community's culture is, what the values are, and also what resources are actually there, because many communities are already doing good work. And so that gets taken into account. Just briefly, sort of how does CTC work and how do we think we can make a difference? And this is a CTC's theory of change. So as I mentioned, the core is really about community capacity building around doing prevention work. And so the core is really to intervene on these coalitions, these community coalitions who drive this kind of work and make decisions around prevention work. And so really, CTC provides training and technical assistance to communities to build their capacity, their functioning to do this kind of work. And by doing that, it is assumed that that actually changes at the community level very broadly, the entire system of how prevention is approached. And that has multiple different factors that are listed here. Those include things like the collaboration across sectors in the community around prevention, support for prevention, which also means how much of the money in the community is actually allocated to prevention versus treatment, because most often we tend to allocate our funds to treatment rather than prevention. And as we heard earlier, once a problem starts, it's very difficult to address it, and it's very costly. And of course, community norms around substance use and sort of youth development more broadly can also be impacted by this. through this process, if we change how coalitions do this kind of work, CTC believes this will lead to the appropriate selection of evidence-based programs, and then also through that implementation, then lead to a decrease in risk levels, enhance protection, and we know if we do that, we'll actually get to positive youth outcomes. And so I don't have time to tell you exactly how CTC sort of operates. I'm happy to talk to you more about it. Just very quickly, it has sort of 5 phases. They're pretty, I think it makes a lot of sense sort of how it's organized. You get started in a community, you actually build the coalition, they get organized, they get trained, they look at data from the community, from youth to make a plan, to actually see what are the issues in our community? What are the risk and protective factors that are either elevated or suppressed in our community right now? And then based on those data, the coalition makes decisions around what kind of programs make sense for us? What do we want to implement? And then over time, you evaluate and sort of that's why it's sort of shown in a circular fashion. Just very briefly, this process, the first 4 phases of planning, takes about a year in a community, if not more. This is sort of a lengthy process. It takes a while. I'll skip through this, but the idea then is after a year or so, the CTC communities are usually ready to then implement programs. And after that happens, we usually see first that risk and protective factors start to change, and only then do we see actually impacts on behavior itself. And then hopefully this is an ongoing process and is sustained. So that's what CTC is. And I used to be at the University of Washington where CTC was developed, and we actually designed a randomized controlled trial to test CTC because we wanted to make sure that how it was designed, that it actually works this way. And so we designed what we called the Community Youth Development Study. And I won't go into the details of the design, just to say that it took place in 24 different communities across 7 states that you can see here on the left, highlighted in yellow. And we randomly assigned entire communities to either get CTC, be trained in it, be supported in it, or not. Control communities still did prevention in the usual way they always have been doing it. And so I wanted to share a few of the results from that, but I want to acknowledge who funded this work, because as you'll see in a moment, this has been a very long-term project for almost 20 years, and the National Institute on Drug Abuse has been supporting that work all this time. And so I want to give you a quick overview, because how we designed the study was to actually test each and every aspect of this theory of change to understand whether this is actually how it worked. And I'm happy to report that we found evidence for every single part of this kind of complicated theory of change. And so just very quickly, we found that indeed the CTC communities were able to fully implement this process, which is kind of complicated, but also sustain it over time, which is a really important aspect for communities. We saw that coalitions indeed increased their internal functioning and had greater capacity to do prevention work. And ultimately, we saw that these different aspects of the community level aspects of prevention work were improved, both sort of in a more immediate way, but also in the long term over several years. And we saw, which I think are sort of the important pieces, because that's what we're trying to get to, is that all CTC communities in the trial implemented programs with high fidelity. As you all know, it's really important that we actually implement the programs the way they were designed to actually get to outcomes. And the CTC communities, through this technical assistance and training, were able to do that. And we saw that the CTC communities compared to the control communities who did not do CTC adopted a greater number of evidence-based programs. They sustained them for a longer time, and also reached more people, youth and families with these programs. So this is really what we're trying to get to, and we were able to show that. And ultimately, we were able to show that we in fact saw decreases in risk, increases in protection, and also better youth outcomes, including substance use. So I'll just show you a couple of quick glimpses of what that actually looked like. This is the study timeline. Don't worry about the details. I just wanted to orient you really quickly. As you can see, the study has been going on for almost 20 years. It started in 2003. When we randomized the communities, and then they started the training in CTC and started implementing the process. And then, as I said, it takes about a year to actually select programs and to start implementing the specific programs. And that started happening about in 2005. We followed this panel, a cohort of youth who were in 5th grade at the beginning of the study. And so every year we would go back and do surveys with them. And that's how we were able to find out whether we actually had impacts on youth outcomes. So they were in 5th grade in 2004. And so basically they're the high school class of 2011. And just remember that because we started seeing impacts for the first time when they were in 8th grade, just as we had hypothesized. It takes there's a little bit of a lag, and we were able to show that. Someone was asking earlier, what are the programs that work to prevent adolescent substance use? Here's a smattering of some of the programs. These are just the programs that were selected by the 12 CTC communities in the trial. And you can see it's a whole range of programs. You might recognize some of them. Big Brothers, Big Sisters is one of them, but also strengthening families. And it's a mixture of school-based programs, after-school programs, and also family-focused programs. Each community selected between 2 and 5. It was sort of a combination. They didn't all do all of these, but just so you have a sense kind of what happened. But this also tells you there's a whole range of programs that have been shown in high-quality studies to prevent adolescent substance use. So the answer to the earlier question is yes, there are programs, and you can look them up, for example, in the Blueprints registry. I also wanted to, since this conference is also around community engagement, I mentioned that CTC is driven by the community. And this is really across all of the sectors in a community. Really, everyone needs to sit at the table for this to work. And these are just the kind of groups and agencies that participated in the coalitions that participated in our study. You can see it's like anyone from business to law enforcement, to juvenile justice, to the schools, to the media, as well as parents and youth themselves. So very quickly, showing you some numbers so this becomes a little bit more concrete. I mentioned that we found that CTC sites had a greater adoption of programs, also sustained them for a longer time, and had greater reach. So what this graph shows you are the actual number of programs that CTC communities in yellow and control communities in red implemented over 7 years. So on the left is baseline. So before the study started, there wasn't much different. Both CTC and control communities did something. They were doing some evidence-based programming. That's good, right? But over time, as CTC coalitions were trained and knew how to do this, you can see it really jumped up in terms of what they were doing, in terms of the number of evidence-based programs. But note that control communities also increased. It also did something, right? So that's good. That's good news, but not quite at that level to reach community saturation. And then this is sort of similar. This just shows the number of participants that were reached. Again, you can see at baseline, there was no difference, but over time you can see there were more programs and they ended up reaching more participants in the CTC compared to the control communities. So this is really what we were trying to affect, and we can actually show it. So quickly, in terms of youth outcomes, we were really interested in substance use, but also other behavioral problems like delinquency. And we looked at the recency of substance use. So we measured that by asking adolescents if they used drugs in the past 30 days. And we actually found that there was a reduction in substance use by the 8th grade. Remember, that's about 1.5 years after programs were started to be implemented. And these are relative risk reductions, not absolute drops. But we saw decreases in alcohol use, binge drinking, as well as smokeless tobacco use. And then in 10th grade, when they were in high school, even later, also cigarette smoking. But we're also very interested in sort of actually this question, can we prevent substance use? And this is what this is, where we actually looked at youth who had not started using at all at the beginning of the study. And then we tracked where they were later on and asked them if they had ever used at any time point. And we see sort of similar reductions in terms of relative reductions starting in 8th grade. And 8th grade developmentally is really when substance use initiation really peaks. So the timing of this is incredibly important. And you can see at the bottom, we also had an impact on delinquency as well. And we were able to sustain that in the 10th grade in high school. This is actually after these youth were exposed to programming itself. So it seems like if you have an impact early on, you carry it with you. Yeah. So this is
the control group?
Yes.
Okay.
Yes, compared to the compared to the control group. Exactly.
All right. And do we know, I mean, it sounds like it is, but is that statistically significant?
Yes.
Is it? Yes.
I'm
Okay.
only showing you statistically significant
you.
effect, but the next slide might give this a little bit more concreteness in terms of the comparison, because I'm not showing you that here. This is sort of showing you the same idea, just more in the long term. So this is the percentage of the youth in the sample who had never used what we called gateway drugs, so either alcohol, cigarettes, or marijuana, or any combination. And this red line is in the control communities. You can see that, of course, over time, as you start initiating, this number drops. But by age 21, only 12% of the youth in control communities had never used gateway drugs. So what is that? Do the math. 88% actually have ever used, right? So that's sort of the flip side. So what did that look like in the CTC communities? It's the blue line and it's higher. So if you can read this as abstinence rates. So in CTC communities, they were more likely to remain abstinent even through age 21 when these drugs become legal. And in the sample where we were located, in most of the states, there was either cannabis was either legal for medical purposes, but also for recreational use. So the fact that we sustained this difference through age 21 is quite amazing. Now, these might not look like very large differences, but I think the sustainment is really incredible. And sort of the absolute difference here is about 7%, which is definitely a meaningful difference. And as I mentioned, at age 21, we did, the formal statistical analyses with controlling for all kinds of things, and it was statistically significant still through young adulthood, and we actually see this even through age 26, and I'm not showing you those numbers. So that this prevention effect actually is long lasting across a lifetime of these participants.
Can I stop you again?
Yes.
I'm sorry. You're just making me really curious. Two questions. Thank you. Two questions occurred to, I guess, us. The use of gateway drugs. Are we using gateway still? I'm curious. Am I behind or what is going on?
No, I don't think you're behind.
Okay.
What we do know that this is still happening, that in part that any of these drugs, they do still tend to lead to the use of other drugs, harder drugs, illegal drugs. This is still the case today. Even we have studies looking at whether vaping can lead to actually cigarette use and so forth. So it does seem to be that this process that was identified like in the 1990s, basically, when we started doing this work, this is still happening. And that maybe this term is a little outdated, but we do know the earlier you start, the more likely you are. It's a quite dramatic increase. It's a risk factor, right? It's not a deterministic relationship. So yes, that is still the case. And yeah.
And then is abstinence the goal? Is abstinence our goal?
I think for youth, I think it is, because as you probably all know, that the brains, we now know, develop way longer. It takes until I think, what is it, age 25 or 26. So I think the idea is that definitely delaying as long as we can is the better thing, it appears. So, but it's a good question. Just very briefly, because I know I'm running out of time. I think importantly, because I think you can tell that the CTC process is quite intense and complex and takes a lot of investment from the community and from everyone involved. But we wanted to make sure that it's worth it, also economically, financially, which I think is an important piece. So we did a cost benefit analysis. I'm not an expert in this field, but if you're interested, I can send you the paper. But we found that it cost about $600 per youth to implement CTC in this trial. But, so that might sound like a lot, but the benefit, the economic benefit of that actually was almost $7,000 per participant. So the net difference, this is called the net present value in economic analysis, is close to $6,000. Or expressed differently, you might see this sometimes. What we can say is that based on our estimate, CTC returned more than $11 per $1 invested. And that's a very good investment. I think other prevention programs or individual programs don't usually have those kinds of returns. So it's expensive, it's intense, it's complicated, but I think we see the effects and we also see the cost benefit as well. So I just wanted to leave you with this. I'm a very big advocate. I think all of our work over the last 20, 30 years has shown that CTC, in fact, is an effective and cost beneficial community level process to prevent adolescent substance use and other behavioral health problems. We definitely have seen this. And if you're interested in this process, feel free to contact me. That's my email. But I'll also point you to the website. It's being supported. It's being supported by the University of Washington. And there's also a book out that was published in 2018. It summarizes everything I've talked about from the development. And also this is being used all across the country, but also internationally, which is an interesting sort of case study. And these two young gentlemen here are actually the developers of CTC, Dr. Rico Catalano and David Hawkins, holding their book. So thank you very much. I'm happy to answer questions, or we can also wait. Thank you.
Okay, I have to ask, I've been teaching evidence-based practice since 2006.
Awesome.
What is your biggest challenge? You have clearly a strong return on investment. We also look at value of investment. I'm sure that's very high with these outcomes. To me, it was very alarming that you have such a large percentage that aren't looking at the evidence and aren't embracing that. What is your biggest challenge? I work interprofessionally, so just kind of wondering, what can we do to help get that, that process of looking and engaging evidence-based practice? Because I know for a lot of professionals, it's like, well, I don't have time. I don't have the expertise to understand the methodology to find the best practices.
Exactly.
How can we support you and your teams and this entire population to be using more evidence-based?
Thank you for that question. I think ultimately it comes down to funding, because this is not necessarily cheap, right? You can hire the University of Washington, the Center for CTC. They do all the training. Basically, we need a community. It could be a school district. It could be a coalition who are interested in engaging in this. You basically have to do the work on the ground to find a champion who is interested to bring this to your community, engage the stakeholders that need to sit at the table, and then we can help you sort of with the whole process. but it costs money, and it costs money for the training and so forth, but it also costs money to actually implement the programs that you end up choosing. So I think ultimately it is sort of this maybe advocacy work to make sure that, you know, if like Arizona has the drug-free, what are they called? Drug-free communities grants, that is actually written into those grants that you have to use evidence-based programs, right? So I think this legislature piece is really important. So lobbying with your policymakers or even in local policymakers to write this in, that we actually need to use evidence-based programs and to use a coalition-based approach as well, so that we're not doing sort of this piecemeal kind of work, but that we come together as a community at the table and then make those decisions together. But I think it's ultimately that will to invest in prevention that is very difficult. But this process also tries to change this over time. So you might sort of start with the initial process of maybe bringing the stakeholders together, forming a coalition. And maybe one of the first things that you might need to do locally is to change sort of that investment in prevention in the community and the norms around it. It's a long-term investment. Yeah. Yeah, thank you for that question. Thank you so much.
All right. Hi, everyone. I'm going to be sensitive to time because I want to make sure that Oakley can present her work too. But I just wanted to start off this presentation. I'm going to be talking to you about music today, right? Which is such a captivating topic, and one that, frankly, I come at from a very, what do I want to say, unprofessional kind of way, right? I'm really passionate about music. I love music. I listen to music all the time. The music I listen to these days is a lot of Baby Shark, which I don't know if you've heard that song, but it's infectious. And I would recommend everyone in the room listen to it at least once. But I'm just going to start this off with just a brief conversation about music. Can anyone tell me just about their favorite song? Does anyone have a favorite song in the room? Yeah. Oh, that's great. That is a classic. And how does that song make you feel? Can you tell me a little bit about what kind of feelings or emotions are elicited from that song? Yeah, pure joy. I love that. Yeah, gorgeous. Anyone else want to tell me their favorite song? Just one more. Wow. Okay. Well, I love the juxtaposition of that. And what tell me a little bit about how that song maybe makes you feel. Yeah. Yeah. Motivated, inspired, alive, right? So already just with these two responses, we can kind of even see the diversity of music that kind of elicits different responses from people. And you can also kind of see how we can use music again as a tool to kind of leverage certain emotions, certain feelings, to reduce stress, to reduce anxiety, right? To start to help us kind of cope with maybe difficult problems or situations in our lives, right? We also see that across these two individuals that very different types of music can kind of elicit similar feelings too, right? So as we go through this presentation, I kind of want to focus a little bit on kind of this healing power of music that we all know exists. And certainly the literature that I will not cover in this presentation today really supports the idea that music has this potential to change attitudes, but to more importantly, help us cope with very stressful emotions, with very, very serious kind of mental health concerns. This can be used and implemented as a tool regularly for all of us to kind of change these important parts of our lives, right? The biggest problem that we wanted to tackle with this project, and I say we because I have another investigator in the room, the former PI of this project, we really wanted to tackle this bias that kind of inherently exists within the focus of music-based interventions. And that's that it's really focused in this pedagogy that's very Anglo-centric, right? Most of the research that is done doesn't have this culturally based component. And as we kind of learned from our last presentation, which I still have ideas whirring as a result of that, culture kind of encapsulates, right, a lot of the ways in which we implement the most successful programming that we have, right? It is kind of the basis of how successful these programs can be. And as you've noticed, I've changed preemptively, even though this is a culturally, again, a a culturally centered addictions research training. This is the idea kind of underlying all of this work, right? That that culturally centered programming is going to be kind of the basis of effective programming in many respects, right? So our focus was specifically within indigenous populations, which of course in Northern Arizona, we have the beauty of having a multitude of tribal nations kind of surrounding Flagstaff in particular. And the focus again comes from this huge disparate issue that kind of remains in indigenous communities that was exacerbated by COVID. So this was all kind of centered in the wake of COVID-19, where we're seeing kind of big changes as a result of the effects of COVID on our communities, right? So overall in Arizona, we have 1 in 5 adults reporting that they have experience with a mental health disorder each year, right? So incredibly high rates of this, much of which has some association with COVID, right? But we see that these impacts were disparately kind of focused in indigenous communities during this time, right? And we also saw this as an artifact of the fact that indigenous people had the highest rates of COVID mortality in the US, kind of bar none, right? And a lot of this has to do, again, with the fact that there are these resource constraints on reservations. There is a lack of access to accessible care. And the idea here, too, is that the effects of this mortality within indigenous communities was incredibly striking, right? What we saw is that we had elders in those communities who held very promising and very important ways of knowing for those communities that are lost as a result, right? Many tribal nations, even outside of Arizona, lost some of the last speakers of their language, which resulted in this huge cultural isolation and spiritual isolation that had these that will have long-lasting impacts on those communities, right? I'm going to, again, kind of work within a group of individuals who I know are maybe experts in this topic, right? Or have a ton of background, but maybe some of us are less familiar. When we think, again, about inequities in indigenous communities, the center of all of this, and kind of there's no way to talk about these inequities without addressing kind of these ongoing consequences of colonization, right? So as we speak about the lack of infrastructure, as we speak about these larger issues in terms of accessibility to certain types of programming. A lot of this has to do, again, with kind of these multiple intersecting historical and political factors that have been engaged with since colonization, right? And a lot of this too is discussed in this concept of historical trauma. Are folks familiar with historical trauma? Can you raise your hand if you are? Okay, yeah, so a lot of folks, yeah, perfect. These are the rooms I love to talk to. As we've seen in other places, this isn't quite common knowledge in the same way, right? But again, this like cumulative, emotional, psychological wounding over the lifespan that originates from, again, this massive group trauma caused by colonization, right? So as we, again, kind of get into a more abstract understanding of how music can kind of fit into this larger conversation, right? We have this framing within the indigenous stress coping model, okay? I have been relying on this over the past 2 years to, I think, really get to the heart of how these types of cultural interventions can really act in a way that interrupts this flow of harm, right? And the origins, again, of all of this, we cannot talk about without talking about historical trauma, without talking about colonization, and without talking about the intergenerational trauma that is caused as a result of all of this, right? When we talk about COVID, there's no way to do that within an indigenous context without addressing kind of this, this historical trauma lens, right? And what we saw, again, is this cultural isolation, this disruption that was caused by the loss of culture throughout many communities during this time, right? What we see, though, within this kind of larger picture is that there are ways to interrupt this effect of stress on negative health outcomes. And this is through coping, okay? This is a coping kind of ideology where as we think about, again, in the conversation between protective factors and risk factors, that coping can act as a protective factor to interrupt any disruptions in health caused by historical trauma, right? It's not going to eliminate it entirely. As you can see, there's still kind of that overarching relationship between stress and health that still exists, but there are ways to disrupt it, right? And as we see here, identified here are spiritual coping techniques and traditional health practices, which fit well within this idea of utilizing music as coping, right? Which is this MBI, this music-based intervention that we sought to build, right? So this Indigenous stress coping model is kind of the foundation of our work. It fits well within this idea that music can be used as a tool to mitigate negative health consequences and to improve our psychological and even physical well-being. And we see this again kind of borne out specifically within Indigenous contexts. However, we lack this ability to kind of utilize music as an intervention in a traditional sense, right? In this framework that has been already established in Anglo context, we lack kind of an understanding of how to do this with an Indigenous focus, right? So our current study, and this is the result of two different pilot projects that I'll talk about both right now, was to evaluate how an intervention like music can guide the development of future clinical interventions at promoting well-being, so to reduce both mental and physical health, negative physical and mental health symptoms, and also affect health outcomes, and specifically in elder care settings is where we're doing right now. But we've also tried this in substance use care facilities that has been fairly effective. And our central hypothesis here is that participants who participate in this MBI that we've constructed, MBI meaning music-based intervention, that will see and they will report a decrease in negative mental health symptomology, anxiety, depression, and perceived stress are the ones we focused on, and as well as physical health symptoms. We focused on chronic pain, and also this utilization in music as coping, right? Which is going to be the tool that disrupts this effect of historical trauma on these health outcomes, right? And what we further hypothesized too, and this is consistent with this Indigenous stress coping model that we use, that we would think that all individuals are going to see gains from this engagement, but that Indigenous participants in particular are going to receive the most gains, right? And if I have some time, maybe I can talk a little bit about what that's been looking like in our current pilot, how we have been anecdotally, because we don't have any finalized data yet, but I can give some kind of stories about how individuals have been experiencing these MBIs, both Indigenous individuals and non-Indigenous individuals, and how differently it's been operating kind of within those populations. But again, within this Indigenous stress coping model, we expect to see that Indigenous participants are going to experience greater gains than the other groups that are participating, right? Okay, so I'll speak a little bit about our initial pilot, which took place in September of 2024 all the way to April of 2025. Katie Momart's in the room, was our original PI. She did an incredible job setting this up. Frankly, she's made my life incredibly easy. And I worked as co-PI kind of alongside of this. We were given some assistance by Rebecca Maniglia, who is another faculty member in our department, in my department specifically, who is very helpful in developing the original curriculum that we've since revised. And we received funding from the NARBA Institute and the Wurgler Chair to complete this first round of the pilot programming, right? We worked with Haven Health and the Peaks, which are two elder care centers that are around town with very different populations, subpopulations within them. Haven Health is predominantly Native, I would say in the area of 70 to 80%, whereas the Peaks is, I would say, predominantly non-Native and I would say white for the most part. And then within the Guidance Center, there are a number of different programs that we were able to operate within, including a youth program, which was also really exciting, right? So we started to pilot test kind of the utilization of a music-based intervention on that subgroup as well. We had a community advisory board that allowed us to kind of talk through the implementation of the curriculum. They reviewed the curriculum. both Sarah Ryan and Megan Callahan have really strong backgrounds in kind of the implementation of music-based programming, which was super helpful. And Tania Witherspoon worked at the Guidance Center and had some really interesting and positive kind of contributions, especially in terms of cultural applicability. So that was really helpful. So within our initial pilot, we had this development of a culturally tailored music-based intervention curriculum, one of two that really exist for Indigenous populations specifically. The other one is called DARTNA. It is exclusively used in substance care settings and is really focused on the utilization of drumming as a tool. What we've found over the course of our project is that while drumming is certainly a prevalent Native tradition, it's not ubiquitous, right? And especially in tribal nations locally, you see the presence of drumming kind of in Diné culture, but less so in Hopi culture and less so in other Northern Arizona tribes, right? So a lot of our work, especially recently, has been kind of disentangling what it means to be pan-Indigenous versus something that can implement and utilize kind of the languages and symbology of multiple cultures, right? So during this initial pilot, we had 11 total MBI groups, which was awesome. So it gave us a really strong kind of basis for the work that we were able to proceed with. We had 18 interviews. This was a mixed method study, which meant we interviewed group facilitators and musicians, as well as some participants in the later session in the spring. And we also had multiple CAB meetings, 6 CAB meetings in total, to go over the curriculum, to go over its implementation, and then to kind of talk through strategies for improvement moving forward, right? I'll talk a little bit about our preliminary findings. So this is the quantitative assessment that we did with a pre-mean and post-mean test. As you can see here, this is going to be a very underpowered study naturally, right? Even though we had 11 groups, making sure that there was low attrition was somewhat difficult and challenging, and especially is in elder care settings. But what we saw preliminarily was that there is these distinct changes and reductions kind of in negative mental health symptomology and even in pain intensity for folks, especially in chronic, who are in chronic pain, right? So the only statistically significant result that was under this, 0.05 threshold was this PHQ-2 depression scale, which is a screener, which essentially means that we are screening folks through this process. We are seeing reductions in whether a person would end up being would be positive for this screening criteria for depression. And ultimately, what we're hoping to do as a result of this is to build in stronger measures and with more robust statistical analyses to kind of show that this actually has kind of the teeth that we expect it to, right? So to just talk broadly, we saw that these depression-related outcomes, this depression screener, showed a significant reduction at the 0.05 level, while average pain intensity over the past 30 days, anxiety, the use of music as coping, and then perceived stress, all of those showed significant changes at the 0.1 level, right? Which again, isn't a strong enough statistical result to kind of lean back on, but sets us up well for an additional pilot to start to test exactly kind of what this looks like moving forward, right? So what we took away kind of from this initial pilot result was that these results support the potential of a culturally grounded MBI to reduce stress and pain, with some evidence suggesting kind of these broader effects on emotional well-being that warrant further investigation, right? In a larger, more powered study, okay? We also saw from our qualitative findings that we have improved holistic health among participants and facilitators, which is a really, I think, important discussion to be had kind of in these contexts, right? When we talk to people who facilitated the intervention, we ended up hearing from people who attended the sessions, right, and helped run the sessions, that it was creating kind of positive outcomes for them too. And in substance care settings and also in elder care settings, places with high degrees of turnover, places with high degrees of stress, in these areas where I think there are opportunities for these interventions to play a positive role in their lives too, they were experiencing gains as well. So that was a really interesting, and I think a finding that we would like to learn a little bit more about. That we saw from these interviews an enhanced sense of belonging and social connection, and then this demonstrated feasibility, accessibility, and broader applicability of music-based interventions in these areas, right? So that was the result of our first pilot. Our second pilot is ongoing. I'll talk a little bit about some changes that we're making. So we have a new community advisory board where we're focusing on the stronger integrations of Indigenous themes across multiple nations. Again, so as I talked about this decreased dependence on drumming, we're moving more into using flute, we're using more into using more percussive instruments like shakers and rattles, and that's been really successful as well. We've been tailoring to improve accessibility to aging populations as well. So involving alternative instruments that allow for folks perhaps with Parkinson's to hold better. And then we're finally providing alternative exercises that don't rely on the internet. We had an entire unit that required a YouTube video. And what we've realized is that especially as you start to implement this in rural populations and on reservations, right? Internet isn't necessarily something that you can consistently rely upon. So the idea here is that we are providing alternative exercises to improve the accessibility for folks in areas without, a consistent internet access to. We've had some research methods changes. So we've created a more rigorous mixed methods methodology and one that is more in line with Indigenous methods as well. So we ask folks to both before and after the class that they engage with to tell us a story or to relay a memory that is related to their experience with the class, right? And to be honest, that's been my favorite part of attending these classes is to hear, again, the different types of engagement that we see with folks who attend these classes. And what we're finding too, again, without speaking too much about the results, because again, we're in very preliminary stages of this new pilot, what you hear from folks who are Native, of course, is going to be, this reminds me of my mother. This reminds me of my auntie. When we went to my first powwow, we heard this chant that the musician played, and like a lot of things that are really connecting and grounding them to cultural experiences that they had in their youth, right? Which is incredibly helpful for aging populations, especially those who have some cognitive decline, right? But for folks who are non-Native, when you ask them those questions, one woman in particular related the experience to me of her traveling to her husband's orchestra performance, right? So everyone has this inherent connection to music in some way, shape, or form. Whether it connects you and grounds you to culture is a different question, but we're still seeing, again, this kind of resulting positive lingering effect that comes from engagement with music altogether, right? And then naturally increasing sample size to improve statistical power has been beneficial too. So the second pilot phase 2 in progress. It's been a really fun and rewarding experience so far. We received the SHIRK PPP, which is the pilot project program. So we have funding over the next 2 years for this effort. We're working with Haven Health and the Peaks again with an understanding that we are trying to better tailor this particular music-based intervention to these aging populations and specifically to the Native folks that exist within these contexts, while still understanding that at the Peaks, there may be potential for positive effects, and we would like to document those as well. Our musicians are incredible, Aaron White and Hunter Redday. They're just the coolest people in the world and frankly make the whole thing really worth it. We have a consistent facilitator who doesn't necessarily work at the center, but helps kind of improve, again, the adherence kind of to the curriculum that we've established, which has been really helpful. And then we have a new advisory board too. Lee, who you'll hear from tomorrow, has been a really helpful member of the community advisory board. And then we have Michelle Wachter, who is the director of the Flagstaff Symphony Orchestra. And then Maureen Russell, who is at NAU and has, again, kind of this like really strong music implementation background. So we've been really lucky and really happy kind of with the community that we've built around this project. So without, again, going into too much detail, I'm just going to give some current progress, right? So between December and February, we had multiple community advisory board meetings. Luckily, we had a curriculum to kind of build off from, but we received some feedback again in the areas that we spoke about. So we have a finalized curriculum. We've started our music classes again. We're 2 weeks away from being done with our first round of implementation, where we'll do our first set of post interviews and qualitative interviews with folks who participated. So at the end of April, we will hopefully have kind of our first round completed. But anyway, incredibly rewarding project. Thank you guys for listening. And if there are any questions, I'm happy to answer them. Okay, thank you.
Just a quick question. Does the project include at all like listening to music, or is it mostly just creating the music?
Yeah, great question. So it's both. It includes active music. It's an active music therapy. But frankly, our musicians are too good that they truly put on performances at different parts of there are sections written into the curriculum where you can have the musician that is delivering the class provide, a song or a chant or a rhythm that would resonate with the group, right? And so there's a lot of room for musicians to kind of utilize their creativity in that context. So there is certainly a listening component embedded in every class, but there is always an active participatory role for the individuals that are in the class as well. And yeah, one of the most beautiful things that I see happen is that one of our musicians will play on a powwow drum and chant, and then others in the room, even though this is supposed to be a listening portion, will know the chant and also repeat it. So it's very powerful stuff. So yeah, hopefully that answers your question. Yeah, cool.
I have a question for you. This is fabulous, really cool project, so creative. Love to see the progress you've already made. What sort of occurred to me as you were presenting, and I of course realized this is pilot work, and you're showing already such promising results, right? I don't think you should downplay the statistical stuff, because statistical significance sort of doesn't really matter that much. But no, I think it's very encouraging results. But what I'm wondering, as you're moving forward and sort of scaling this up, if you've thought about it all, how you can show more convincingly that it's actually the music-based intervention. Like you don't have a comparison group in your pilot work, which makes sense. That's where we usually start. But have you thought about what would make sense to actually sort of convincingly show that it's the music and not like, let's say, just, it could be a creative engagement or just being engaged or something like it. What are your thoughts on that?
Yeah, it's an incredible question. And to be fair, you were hard to follow. So I felt like I had to downplay a little bit. But the idea here, so that is something that that both Katie and I have talked about and discussed kind of in this context, right? And while we would have loved in our RCT for this, I think our biggest issue is the kind of ethics of doing so with aging populations and especially with Native populations. So that was something that was in the back of our mind. What we've constructed now, and again, this is all hinging on an appropriate sample size, would be a dose response model. So looking specifically at the number of classes that folks are attending, looking at the impact of each individual class, and seeing again if there are differences in, perhaps someone who had only attended like 2 classes versus someone who attended 6, right? So it does kind of in some way account for the fact that they're engaging with music more, but it doesn't necessarily, I think, again, to your bigger concern, these could just be people who are just engaged in programming altogether, right? They could just be a more engaged kind of subgroup of people that we're looking at, right? Which is, I think, a lot of the reason for the mixed methods model that we're using too. So hopefully we can use the qualitative data that we're collecting to kind of back up and help us understand kind of the mechanism underlying these changes as well. So unfortunately that wasn't not an ideal answer, but hoping that, again, that the story that we're creating with both the qual and quantitative data can back up the claims that we're making with all of this. Yeah, thanks. Mhm. Yeah.
Because you have such small sample sizes,
Mhm.
have you run effect sizes?
That, again, a great question. Not quite. Not with a small. Not with
I
a
mean, I
small-
work with a lot of doctoral students or
Mhm.
DNP students. They don't have large sample size.
Yeah.
So we always encourage them to run a Cohen's D or a Hedges G. And what that does with that small sample size allows you to see the impact of the intervention.
Sure.
And while it may not be statistically significant, you may be able to show
Okay.
that you are having an effect, whether it's a moderate to a large effect,
Okay.
even though you're not getting the statistical numbers from power.
Okay.
But I love the fact that you're doing the mixed methods, and the strength of the qualitative data is going to give you the whole different story
Mhm.
of what people are really experiencing. So I think for pilots, it's really strong. But I
Okay.
think it's very exciting work that you're doing. But don't forget to take credit for the fact, I think you're under, you, even though you only had one area that was statistically significant.
Mhm.
Effect calculators are easy to use.
Okay.
It would take you a couple of minutes to run that data. You need a sample size, you need your mean, standard deviation.
Mhm.
You can put the data in there and it can tell you, okay, yeah, we weren't statistically significant, but with this group of 28 or 30, we did see a moderate to large
Okay.
effect size, or even, I mean, I've had students that go, I had nothing statistically significant, but look, I did have a large effect size. So it warrants then more research and more study.
Okay.
So you've got data there that you can just run very quickly, another statistic, and you may be able to find some interesting
Okay,
findings there.
thank you for the advice. I'm going to focus on effect sizes, and we haven't published off this yet, so this is great to know before we try to. Okay, cool. Okay, amazing. Thank you. I know. Thanks, guys. Oh, I don't want to take my. All right. Well, I know it's been a long day. I don't know about for you all, but probably for most, I would assume. So hopefully this will be interesting. You will learn some new things, which is always exciting. And then we'll be finished. So my name is Oakley. I'm an occupational therapist, and I am so excited to present about a project that I've been working on for about the last 6 years called Dad's Club. So just to give a little bit of background, about 40% of families will have a child under the age of 18. Anybody here a parent? Raise your hand, right? So I think we can all say that could be one of our primary occupations that we engage in, that we love. It gives us a lot of meaning and it's exciting. It gives us roles and routines. However, it can also be very challenging, right? Parenting doesn't come with a handbook. Well, for about 1 in 8 children, they will live with a parent who has a substance use disorder. So that is a lot of kids. And obviously, we've heard a lot tonight how that can negatively impact them as they grow older. So when we look at parents with addiction, living with a parent who has an addiction, obviously there can be additional circumstances that go with that. So the home environment can be more stressful. There can lack consistent routines. There can be a lot of emotional and behavioral imbalances that happen. That you can have these poor parenting habits where maybe you have more aggressive parenting styles, or you lack disciplinary practices. So obviously, did I change that? No. Okay. I'm hitting buttons. Sorry. So obviously for the child, they would also experience some adverse outcomes as well. More likely, individuals who live with a parent who has an addiction, they can experience neglect, abuse, live in lower socioeconomic status, be placed in risky situations. And like we've heard, they can also, they're more likely to develop an addiction themselves. So there is very limited research focusing on fathers. However, fathers can play a large part of that family milieu and on the impact of their child's lives. So what I want to talk about is, why did I get into this? Where did kind of this OT world and my experience come in? Well, obviously recovery is possible. And so when I was working in a residential substance use disorder treatment facility and I was running OT groups, I would ask the guys that I was working with, I was like, well, what's your motivation? You know, why are you here? What do you want to do when you transition out? And I kept hearing over and over again, it's because I want to be a better dad. I want to be reconnected with my family. I want to, you know, have my kids back in my life. And obviously there's research to support that being a parent is a motivator to seek and complete this treatment once when individuals are in their care, but also to stay sober. So like any good clinician, I look at the research and I'm like, well, what's out there? Specifically what's out there in occupational therapy, but also what is out there for fathers. And there's very limited research out there for parenting programs. And in particular, within my profession, occupational therapy, I could find nothing about this area of practice. So I was like, all right, well, here we go. This is what I'm going to spend my time doing. So with occupational therapy, I just want to give a broad overview because not everybody is very familiar with our profession, but we work with individuals across the lifespan, engage in things that they need and want to do. And often people, this is where maybe you'll learn something new tonight. Often people do not know that occupational therapy was actually started in mental health and working in the mental health field. So this is a very synergistic area of practice. However, we've kind of strayed away from that over the years. And so you may be more familiar with, you know, OTs in the school or in homes or in the elder care facilities as well. But in occupational perspective, when we look at individuals who have an addiction, it is very occupational in nature. It is now one of their primary occupations in which they engage. So similar to parenting, it gives them an established role. It gives them habits that they're engaging in, routines. It's consuming their time. And so that becomes that primary occupation. So when you look at occupational therapy, we focus on how do we help individuals with that quality of life. And once when they're no longer using those substances, how can we help to prevent that relapse as well? This graphic over here just shows you the different areas of occupation that we help individuals engage in. In particular, when we look at parenting, that is part of what we call instrumental activities of daily living, or that co-occupation of how do you care for your child. But being a parent, typically you have to, you know, take care of the home, you have to be able to work or manage your finances if you're receiving funding from other places. So there's different areas that we can help focus and work with the individuals on beyond just that co-occupation of helping that person to be a parent. So as I mentioned, when I was looking at what are the current parenting programs, I was looking at parenting programs and occupational therapy, parenting programs, addiction, and everything that I was finding, or the majority, was all about mothers, which is amazing. And there is a huge need, and we need to continue to focus on parenting programs with mothers, but we are missing this whole other area that can really help the child and the parent themselves with the fathers. So what the research shows is that these parenting programs for mothers are very effective and beneficial, not only for that parent, but also for the child. When fathers are in treatment, they have reported having a positive view of fatherhood and wanting to improve that parenting role. So once again, looking at that intrinsic motivation is really important. And there's emerging evidence for parenting programs that are focused on fathers, that it is beneficial, that they would decrease their substance use and increase their parental self-efficacy. So that has led to Dad's Club, or the Dedicated Attentive Dads Club. I want to give a big shout out to my community partner, Crossroads, which is a large organization in the Phoenix Valley. With this collaboration, we co-developed this program because it was really important to not just look at what is evidence-based, but what does that community, their feedback, and what would work for that program. And so they actually, the dads that helped to create this program, they helped named it as well. So
So Dad's Club is a 5-week parenting program, and this just gives you the large overview of what we focus on in each one of those 5 weeks. And we'll go into what each week includes, but I do just want to give you a little bit of kind of the methodology, because we did do a pilot study just to really see, is this effective? Is it working? Is it worth continuing? Do we need to refine it? And obviously the answer is always yes. So week 1, parental self-awareness, focusing on life balance and parenting stress management, because anybody who's a parent or if you've cared for a child, you know that that is very stressful and it's a lot. What are the roles and responsibilities, not only now, but also in the future? And healthy communication. That's, you can see that that was 2 of the sessions that we focused on, because we kept hearing from the fathers that I need to learn how to communicate with the child. But more importantly, I need to figure out how to communicate or work with communicating to the other caregiver of that child, because oftentimes that could be a really difficult relationship, or as a lot of them said, the baby mama. I need to figure out how to talk to my baby mama. I was like, okay, well, we can work on that. So what did we do? It was a longitudinal intervention study. So we offered this program 3 times over the course of about a year. This was at the tail end of COVID. So Crossroads was offering all of their outpatient services virtually. So we did this by Zoom. We offered the 5-week program. And so the participants would join 1 time a week for 3 hours. And if anybody's been on a 3-hour Zoom, you know that that is tedious. So anybody who's online, I apologize. So when designing this, we really thought about, okay, we know it's virtual. How do we make it interactive? So hopefully, as you see kind of the programming that we did, you can get an appreciation for that. Individuals could enroll if they were 18 years old and if they were enrolled in the Crossroads outpatient program. So they had to be a client of that organization. And then what we did is pre and post surveys. So we did a pre-program survey where we did it at the very beginning of the 5 weeks and the very end. And that included a validated tool called the Parenting Sense of Competence, which looked at, self-efficacy, knowledge and skills. And so that was at the very beginning and the very end. And then we also looked at their specific knowledge and skills with each session, because we wanted to know, is that OT information that we are providing in each session, is that beneficial or not beneficial? So the first session was about parental self-awareness. So we did an introduction to the group and an introduction to the group members. Something that we didn't realize until the end was how important having this connection outside of their addiction was so beneficial for the group members. So anytime that we would start the group, we always talked about saying, how was your week? Anything special? Can you share something that was a win for being a parent that week? And so they started to build that community of dads, which was really great. So we did the introduction to the group, introduction to each other, and then we did the CAWA model, which is an OT specific framework that uses a concept of a river, and they designed their life using different pieces of the river. So in particular, if you can see this picture here, we have them draw, what is your previous role as a father in this river? Where are you currently at? And where do you see yourself? So if you can see this little picture here, there's this life river, and here's the person right here. Okay, so this is where they're drowning. And when they would draw pictures, you would have people in this waterfall at the end of this waterfall, or we would have, you would have to draw pictures of boulders. And so what in these boulders are holding you back or are getting in your way? So for this person, it was self-doubt or fear. And then you had the banks of the river, and these were your support. So every piece of the river meant something different. And what was really interesting was to see where their river started, where they were at right now, and where they wanted to see it go. And so after this river, we wanted them to develop what is just one goal as a parent over this next week that you want to accomplish. And in this session, we always ended, because I'm an educator. So I was like, okay, you have homework, right? Everybody loves homework. Well, you need to now share this picture of the river with somebody that you feel comfortable with sharing, because it can be a pretty vulnerable place to look back and to see where it's at. I had a dad draw a picture of him in a shark's mouth, so I mean, right, the way that they represent it is just all in different ways. So they needed to share that. In week 2, we focused on life balance and parenting stress management. So we started once again connecting as dads and where they were at. If they had any wins, we always do a check-in. How did you do with your homework? Were you able to do it? Were you not able to do it? But then we went into the wheel of life, and what we did is it's a visual for them to be able to see how well are you doing at different areas of your life. But what we added in recovery and we added in parenting. So if you see this kind of spider web, when you're more at the central piece of that spider web or right in the middle, it's on a scale of 0 to 10. 0 being you're doing well at it, 10 being or 0 being you're not doing well at it, and 10 being you're doing amazing at it. So in each area, leisure, recovery, family, friends, romance, home environment, they would go in and actually map out how they thought that they were doing, either being successful at it, not successful. So this just gave them a nice visual of what it is that they maybe were doing well or not doing well. So then we would start to discuss, well, leading into this, what are the areas that are causing stress, right? So one of my amazing students created this coping skills guide, and we then talked about what are some different coping skills. So we actually had them practice. They had to create mantras, and we all practiced different mantras. We used I feel statements, mindfulness. So they would actually participate in these different coping strategies. So then their homework for that was you need to practice one coping strategy when you start to feel overwhelmed or stressed. Next was focusing on parenting roles and responsibilities. And this was really looking at what are your current roles. So yes, you may be a parent, but you likely have other roles that you're engaged in, being an employee, being a son, a brother, a partner, whatever that may be, a caretaker. So we really wanted to focus on what were you engaged in and what were those responsibilities currently, and then also in the future. So starting to plan forward of, okay, well, this is where I'm at right now. Probably, an outpatient treatment, a little bit more of a supportive environment, but what does that look like going forward? And then from that, then we had them create vision boards for how they wanted to see their future self. So they could draw it. We had, obviously people can be very creative, write it. They would use all different things. So imagine this over Zoom, and you have a whole bunch of guys with their arts and crafts stuff creating. And I think what was one of the really great things is when I start to say, hey, we're going to draw this, or hey, get some magazines and scissors, we're going to do this. They're like, really? But by the end, you can tell that they really got into it. So the homework for this week was that they needed to share the vision board with someone or create a vision board with their child. The next one, we had talked about healthy communication, not only with the child, but with the other caregiver of their child. So really focusing on what does effective communication like? What are the different styles of communication, aggressive, passive, assertive? A big area that a lot of the dads had talked about struggling with is how do you establish boundaries? I don't know about for you, but that can be a real challenge of how do you have those healthy boundaries, especially when there's this whole layer of guilt as a parent, which is often the case with individuals who have substance use disorder. And then active listening. So once again, we tried to give hands out. So that way, as we were going through these different activities, then they were able to visually see it and then be able to take, quote unquote, that home as a resource for them. So to think about active listening and effective communications, everybody sees this
picture here in the middle. We would break into groups and we would have one dad describe the picture while the other dad was having to draw it without visually seeing it, right? So I'm sure you maybe have all participated in something like this, but it's just an opportunity for them to practice those skills and then talk about, okay, well, what does that look like when you are really trying to be a parent and work on that communication with your child and the other caregiver of your child. So then we had, for their homework is that you need to practice some of those communication skills that we had discussed over the course of that week. The last week was once again also focused on the healthy communication, and we focused on how do you use I statements and how do you do that. And this was a big one with either if people had older children, but also with the other caregiver of their children. How do you use those I statements when things are not going well or the communication is not being effective? An area that we had really kind of noticed is for a lot of these dads, they said that it was really difficult to show love. And oftentimes they may not have received love and been shown love in certain ways as they were growing up. So anybody heard of the 5 love languages before? Kinda, sorta. There's these different love languages that you have. And there's one that you can either do with a partner or you can do it with your children. So we use that concept as a tangible activity of, okay, these are some different ways that you can show love to your child. So even just understanding that, you know, if your child wants to play a video game, are you able to sit there and play a video game and talk to them about it? Or if your child is always, you know, wanting to wrestle or play with you, you know, is that kind of physical touch that they want to be close to you? So that was really helpful for the dads to start to see, okay, this is maybe how my child wants to receive love, or being able to observe what it is that they appreciate or enjoy. And this is how I can help, you know, be able to meet them where they're at. And then lastly, because this was the 5th group, we really wanted to look at more of long-term goals. So we taught them, okay, how do you write a SMART goal? And we're going to write a SMART goal for the 1 month, 3 month, and 6 month mark. And then obviously the homework, because this was their last session, was to actually work on those goals. So what were our findings? So we had a total of 43 people who started the group. Unfortunately, we did have very high attrition, and so we only had 13 complete the entire program. The majority of the individuals were in recovery for less than a year because they were in that intensive outpatient setting, which is probably to be expected. The average time of their length of addiction was 18 years, so a pretty significant period, and it really did range. And for the parents, the number of children that they had ranged from 1 to 6. And then we just collected, you know, what were those primary drugs that they used. We did collect different demographic data. So we had a diverse group of individuals that were participating in the program. So some of the findings, I'm sorry, this table is probably hard to see, but over the course of the 5 weeks, we did see a statistically significant change in the parenting sense of competence scale, which was pretty exciting over those 5 weeks. However, when we looked at more of those short-term pre-post session surveys, we noticed that it either kind of stayed the same or it improved slightly. However, due to sample size, you know, there was no statistically significant. However, taking our wonderful advice, we will look, you know, yep, at the effect size right there. Amazing to partner with statisticians who do all of this. So what is not in this piece is that we did have, or we are implementing a 3 month and a 6 month follow-up to then see how has this program impacted you more in the long term. But that wasn't a piece of that, but just as a side. So where are we at? What do we do? So because we had such high attrition rate, we've decided to move it to a 4-week program. Crossroads was no longer offering virtual modality. So we went in person. We've been doing that. And then because I've relocated and I just recently started to work with a new community partner. So we will continue to offer it at Crossroads and then continue to offer it at a new facility in Boise. These are some of the quotes that are in here from parents who did participate in those. And this was just after one of the post sessions. So we are seeing that it is impactful and it is helpful. So with that, any questions?
Was a huge issue. Thank you. Yeah, the attrition's probably a huge problem, and I've worked with parenting programs before. What were your ideas for how to address that, or is there anything you would do differently?
Yeah. So I think going down to a 4-week, we've implemented this now twice since doing this, and we've not had as high of attrition. So we're doing it. And I also think offering it in person when people are on Zoom land, it's a lot easier to not know if they're completing the survey or if they're even engaged. And so I think those are some things. We've also, which seems so simple, but we've started to do a certificate of completion. So although specifically in Arizona, this parenting program doesn't go towards any of your DCS hours, dads have said, I have taken the certificate of completion and I've been able to show that I'm working towards this. And so those are a few things that we've started to do that we're seeing benefit from. Okay.
This is a quick question, but I'm wondering, offering in person, I think definitely would be a solution to that. Have you considered offering childcare at the same time, which I know is, again, a big ask, but I think would also really improve the implementation.
Yeah.
But it would be pricey. So is that a thought you guys have had?
So we've only done this in partnership with the facilities, and we've been offering it at the same time that they've been running their typical programs. And so that's a great question, but I would think it would probably be up to the site and if they could manage that. And I haven't seen that be available. So yeah.
Insurance as soon as you bring kids there.
Yeah, it would be amazing if we could start to bring the child into the sessions, but we really haven't gotten to that point yet. And for a lot of these dads, they're not even in contact with their child. So one of my greatest, I will say, wins, and that maybe we could end with, is one of the dads when I did my 3-month follow-up interview, and I said, okay, well, what is your biggest win over, since finishing Dad's Club? And he had reconnected with his daughter who he hadn't talked to in 10 years. And he was like, it was because of that program that I had the confidence to reach out to her and to start that conversation. And so those are the kind of things that, gives me goosebumps every time. Yeah. Yes, thank you.
Well, I think I want to just thank all of our presenters again this evening. You all have done such a great job and really provided a great segue into our conference tomorrow too. And so I hope that some of you can attend tomorrow. I mean, I know several of you are going to be there tomorrow, but I hope some of our guests from the community might be able to come too. And that starts at around 9 o'clock tomorrow. And that's going to be in the College of Education, not here. So let us know if you need directions or parking information or anything like that, if you can make it tomorrow. Ramona, I don't know if you have anything else you'd like to say too, but I just am really thrilled. And then after that event, we have a special kind of graduation ceremony for our students, or our scholars, as we call them, the CCART scholars. And that's going to be back over here, right? At
Yes,
the
over here,
High
High Country
Country
Conference Center.
Yeah. Is that at 5 o'clock? I believe so.
5 to 7.
Yeah. So feel free to come to that too. More food.
Yeah, we're gonna do heavy appetizers, drinks, so come hungry.
Yeah. So thanks again to our staff who helped put all this on. And thanks to all of you for being here. So we'll see you all tomorrow. Thanks again.
And if just one last thing.
Oh.
This is mostly so we can improve on these next year and get some future research topics. But if you could just take a minute to fill out our very brief survey. But I'm definitely interested in potential research topics, something we can do for next year, the year beyond that. But thanks again, everyone, for coming. Thanks to our AV crew, AV Monkey and Aaron. Also, thanks to everyone who participated in planning. It takes a village to put these things on. So have a great night. And hopefully we'll see you tomorrow.